idiopathic conditions and represent a group of intestinal disorders that cause prolonged inflammation of the digestive tract. So inflammatory bowel disease represent a group of intestinal disorders that cause prolonged inflammation of the digestive tract. It's actually idiopathic inflammatory conditions. The two most common groups, one is known as ulcerative colitis and other one is Crohn's disease. By the term ulcerative colitis, it involves mostly the colon and is the disease that causes mucosal inflammation and ulcers in the lining of the lower intestine. Crohn's disease is another entity which involves the move from the mouth to the anus. Mostly it is involving the small intestine. Crohn's disease is a chronic, relapsing and remitting inflammatory diseases of the gastrointestinal tract affecting any side. But mostly you find rectum is appearing in this condition. Here you can see the difference between the Crohn's and ulcerative colitis. In the Crohn's, you find that the outer layer in the serosa is covered with a fat wrapping. Fat is overlying there. While in the ulcerative colitis, you may find only the mucosal changes, ulceration within the mucosa. Here, in the Crohn's disease, muscular hypertrophy, and both can be present, ulcerative colitis and Crohn's with the fissures, but the diagnostic, the macroscopic or the microscopic in the Crohn's, you may find cobalt stone appearance. White spaces, see over here, these are the white spaces, the cobalt stone appearance. Ulceration within the mucosa is a common sign, hyperemia, inflammatory signs, you see redness, these you will find in the ulcerative colitis. In United States, it's currently estimated the millions of the people suffer from IBD. It's the most commonest disease, ulcerative colitis, in male, while Crohn's found frequently in the women. The reason, the diet, the oral contraceptives, perinatal and childhood infection is playing role for IBD in the females. The etiology, the infectious agents suggested that the virus, measles, bacteria, atypical mycobacteria, genetical predisposition, and definitely the dieting factors, smoking. Though the smoking has a positive role in ulcerative colitis, but negative role, predisposing role in Crohn's disease. Psychological factors, stress, emotional or physical trauma is most common factors found in the ulcerative colitis too. So how these conditions can develop, how these virus, bacteria, diet, smoking, stress, emotion can lead to the pathophysiology. They alter the mucosal immune response of the patient. Through the dietary and bacterial antigens, they penetrate into the intestinal wall and activate the immune system, which leads to pro-inflammatory mediators release and leads to inflammation of the mucosal layer. How they influx? They influx through the endothelial damage, and so they activate activated by bacteriological cells, macrophages, and they leads to the release of these inflammatory cells, most and uh, T4, CD4, and T cells to increase the accumulation of the leukocytes from the endothelial leakage of the vascular system, which leads to activate at the disease portion. This influx is promoted by the expression of ADN molecules on the surface of endothelial cells, the microvasculature, so they remain for a longer period and produce the symptoms. Here you can see the source from where these this prone activation of the inflammatory cells occurs. This source is from the bacteria of the diet, macrophages, T cell, adipocyte, and fibroblasts. They all releases the tumor necrotic factors, which leads to endothelial cell damage. And this damage, this effect mechanism result with new vascular formation and hypervascularization. Macrophages, they also activate the interleukin 1 and 6 and tumor necrotic factors, and this suppresses the regulatory macrophages of the host. The Pennant cells, fibroblasts, effector T cells, they all play in the role to impair the barrier function or they lead to the cell's destruction or the death. So the endothelial cell, macrophages, fibroblasts, effector T cells, CD4 cells, they all lead to the activation of the leukocytes from the release from the vascular endothelium, and they accumulated at the site of the inflammation and they remain persistent over time and the patient is present with different clinical manifestations. In the both cases, in the ulcerative colitis and in the Crohn's disease, the mostly patient present was with the GI symptoms, is known as intestinal manifestations. Like diarrhea, sometimes you find constipation, and sometimes your patients alternate bowel habits like diarrhea and the constipation. And abdominal pain, character abdominal cramping and bloating due to the bowel obstruction, hematochezia, blood in the stool, low-grade fever, and your patients present with a decreased appetite, which leads to the weight loss and anorexia, fatigability, and arthritis. How would you diagnose this? You will diagnose by history, clinical examination, endoscopy, biopsy, radiological investigation, and some other tests, which may help us to establish the diagnosis. The physical examination, as I mentioned, the Crohn's may mark from the mouth to the anus, so you have to start from oral for ulcers, abdominal tenderness and masses. The patient may present anal tags, fissures, fistula, and the signs of nutritional deficiency. You may find your patients anemic, malnourished. These all things you will find. An important feature, the children's growth retardation. Colonoscopy and endoscopy or sigmoidoscopy. This depends upon the length. You see over here. You have to go through the anus or the colonoscopy and have to cross it. This is the ileocecal wall. So to rule out, mostly the colon is involved by ulcerative colitis. Ulcerative colitis, you may find the rectum spare. The colon is mostly there. But in cases of Crohn's disease, you may need to upper GI endoscopy in the Crohn's disease, as mostly involved with this part of the terminal. So you have to go for the colonoscopy to determine the diagnosis, and then endoscopy features. You may find the infiltrate ulceration ulcers, mucosal redness. You have to differentiate ulcerative from the Crohn's or other malignancies. Biopsy, when you go for the colonoscopy, you have to take the biopsy. You see over here, rectal or colonoscopy should be examined. Ulcerative versus collagenous diseases, microscopic inflation, and microscopic small. This is colitis, and this is a growth. You take the biopsy from the result and to send it to establishes the diagnosis. Very many nowadays, we mostly, after the introduction of the colonoscopy, usually it's not used. So the perineum, the perineum inserted to the rectum, and they use the fluoroscopy and the X-rays of the bowel images, identify the colon structure. There's a complication of ulcerative colitis. See the structure, the fistula formation and communication of other organs. Blood test, as I mentioned, the patient are malnourished. You have to look for the anemia, blood CP to rule out the reason of the anemia, either it's due to blood loss, iron deficiency, or vitamin deficiency. Albumin level, because the patient is present with malabsorption, and inflammation markers like C-reactive proteins. And you have to also see your patient with anti-Saccharomyces antibodies positive. This is actually a prognostic factors. So these are the things, blood tests, baseline blood test to rule out the anemia, albumin level, and sometimes you have to suggest your patient to see the anti-nuclear antibody, ANC, AAC. This is a very important chart. You have to differentiate between the Crohn's disease and ulcerative colitis. You see the Crohn's disease mostly involving the terminal, and ulcerative colitis always involving the colon. Rectum is usually involved, but in the Crohn's rectum is mostly spared. This is the difference. Ulcerative colitis is not common in the peripheral region, but Crohn's is common. High rate of cholangitis is common in ulcerative colitis patients. It's extra-intestinal manifestation. Distribution of the diseases. In Crohn's, you have found the skipping. One part of the intestine is involved and other is not. But in the ulcerative colitis, you find continuous involvement of the mucosa. In the patchy area of inflammation, this is known as ischemia. So you find in Crohn's disease, one part is healthy, one part is unhealthy, one part is healthy, and you see the ulcer in the ulcerative colitis, there will be continuous ulcers. So continuous inflammation, continuous ulceration, but here you have snake-like ulcers, deep, because the Crohn's disease involving the muscular portion of the intestine, and the ulcerative colitis involving the mucosal portion. So you find depth of inflammation is up to the mucosa, fistulas, and stenosis is most common in the Crohn's diseases, because again stenosis or structure, they are due to the shrinkage or fibrosis of the muscular portion of the intestine, which is involved with Crohn's diseases. Autoimmune diseases, they have a definitive relation with the Crohn's diseases. Cytokine response in the both cases, but its number is different. In the biopsy, you see these are the non-causating type of the granulomatous disorders. both the diseases. So, but if you differentiate it from the tuberculosis has a caseating type of the granuloma, but here is a non-caseating type of the Crohn's disease. While ulcerative colitis, you will find no granuloma. Surgical cure, remove the affected part, okay, you have good results because it's a escape lane. One part, one segment of the intestine which is involved, you can cut it, and your patient must go through. But in the ulcerative colitis, when surgery is indicated, then we usually remove the total colon because it's continuous inflammation of the mucosa of the whole colon. So you cannot get a good result, or you may find the recurrence rate is high with a segmental resection in the cases of ulcerative colitis. But in the Crohn's disease, segmental resection is good result. Smoking, as I mentioned, smoking is even said as a protective in the ulcerative colitis, but in the Crohn's disease, this can lead to the increase the number of the patient. Goals of treatment in your patient are mostly present with the GI disturbances, intestinal manifestations. So you need to improve and maintain the quality of the life. This first goal. Then yes, definitely you terminate, you have to stop, you have to slow down the relaxes and the recurrence, the frequency of the symptoms and the diseases. Then to reduce the complications and avoid the surgery if possible. So the inflammatory bowel disease treatment, severe surgery, in the severe cases, the complication of the fistulas formation, fissures formation, and you found the structure and your patient may present with the obstruction. Then in moderate cases, you have to do steroid therapies, immunomodulators. In the mild cases, antibiotics. Thank you very much. सही है चौक चढ़ा लेंगे खैर को लग रही है अस्सलाम वालेकुम